What I'd like to do today is guide you through a few related topics. The first thing I'm going to do is talk to you about the governance mechanisms that we use to regulate health data and the regulatory foundations. So in other words, what do we mean when we talk about data governance? What are we doing in practice? And how does the law enable us to do that? What is the legal infrastructure that lets us govern health data for secondary use the way we do? The second thing that I want to do is to point to some ongoing changes in the way we regulate health information, specifically a shift away from relying on bioethics institutions. So in other words, research ethics committees that are based in health research organizations, towards the use of data protection institutions to regulate health information. So in other words, top-down rules that tend to be imposed by specialized privacy regulators. And I'm going to argue that this shift responds to a real policy challenge, specifically the shift from institution-specific data generation and use to network-based information generation and use, wherein many different institutions are collaborating together in the common use of health information, and that while that shift towards data protection recognizes a real ongoing policy problem, that it is barking up the wrong tree, and that shifting towards data protection as the privileged way of thinking about the biomedical data commons, about biomedical data use, is actually liable to have a chilling effect on the use of information and ultimately to detract from rather than building upon our existing health information commons. So this is a very quick roadmap of the different issues that we're going to talk about, and just a very quick colloquial set of definitions. What do we mean when we talk about data governance? Data governance means two things. First of all, technological infrastructures that actually host data on servers, virtual machines, what have you, enable us to query it and discover that it's there, and give us compute and other infrastructure to analyze it. Secondly, and frankly more importantly, organizational processes. So rules about how we generate information, who we share it with, who we're allowed to share it with, and who makes determinations as to whether or not a secondary user should be allowed to have access to pre-existing data. Why do we do data governance? For a lot of reasons. We want to generate reproducible research. We want to generate more value out of existing research data. We want to enable large-scale studies that require data from multiple different sites, multiple different locations. We want to develop AI that can be generalized into public health activities, into clinical care activities. Data governance also means protecting patients and research participants from potential privacy risks, from the misuse of their information, and to ensure that the outputs of the use of health information are generalizable to the entire population, that they don't just reflect the health circumstances or the interests of a small subset of the population. So these are some of the reasons for which we govern access to data, and some of the reasons that we try and enable a secondary use of data whilst also mitigating the associated risks. Now, what do we mean in practice when we talk about data governance? So far, we've been pretty nebulous with that language. Essentially, data governance means slotting data into distinct tiers of risk and making it available to secondary users according to those different tiers of risk. So we usually think about tiered access and access from the most opened onto the most controlled. Open access is generally used to share data that's either consented for a full open release, or data that has a lower risk of causing individual re-identification or causing harm to patients. So aggregated health information is generally shared in open access. The results of an analysis across an entire cohort of patients, for instance, could be shared in open access, whereas the underlying individual level information generally can't be, as well as information that is individual specific but carries no real health risk. So for instance, if at the record level, the existence of a particular diagnosis plus, say, a few other individual identifiers, things like your age or gender, those things can generally be shared open access on the justification that, yes, it's individual specific, but it's not unique enough to allow a person to be singled out, and there's no real prospect of that information being misused to harm the underlying individual. Registered access is data that's made available to a large pool of users who provide credentials showing that they're authorized to have access to that information, but it doesn't involve a deep vetting of the individual's intended use of the data and who they are. So to gain access to registered access data, you would generally need to create an account, show that you're a researcher or a clinician, another individual who has a good justification for accessing that information, but go no further than that. And then lastly, when we think about controlled data, this is a much more rigorous governance process. It generally requires individuals who want to use the data to apply for a purpose-specific authorization to access and use that information. So here we're thinking databases like the European Genomics Archive, dbGaP, the International Cancer Genome Consortium, really repositories that host very granular individual level information, sometimes even part or the entirety of a person's genomic sequence, or very rich clinical records, and make that available to secondary users on a case-specific basis for a clear research purpose. So that's how things are done in practice. Now, how did we get there from a regulatory standpoint? In other words, what goes into letting us share data that way? Why is it legal and even required to implement all of these institutions? What gives us the right to go and take patients' information, research participants' information, and make secondary use thereof? And the main mechanism is Canadian data privacy law. But before we get to Canadian data privacy law, we need to understand the regulatory history that gave us the kinds of privacy legislation that we have today. So this gentleman is Louis Brandeis, and he is one of the justices of the United States Supreme Court that was on the court in the early 1900s. And this quote of his was written in 1890. Louis Brandeis is relevant to us because he's one of the fathers of American privacy law and of global privacy law. He proposed a very narrow, circumscribed definition of privacy rights and said, well, individuals should have a right to privacy in information that is unique to them in contexts where they expect to have privacy and to not have that information shared with secondary users. So his conception of privacy was narrow and limited in the sense that it applied both to circumscribed information that's private to the individual and that it applied only in contexts where the individual had a reasonable expectation that their information would be held private. And this feels probably very shallow to us. As a conception of privacy, our thinking about privacy has become much more nuanced with time, but he was really one of the first people to write about legal entitlements to privacy within the context of the legal system. Secondly, here we have Alan Weston, who was writing in the 1960s, and he was writing at a time when information technologies were already starting to seep into everybody's day-to-day life, and where information exchange using telephones, computers was already starting to be pervasive, and information was being used to make decisions about individuals. So he was writing in the post-World War II context when there was a lot of discourse about how a lot of the wartime atrocities that had been carried out had been enabled by the pervasive collection of information about citizens, and he argued for a much deeper right of privacy. He said, well, individuals actually have a right to self-determination and an interest in all of the information that's generated about them, no matter how it's used, not just if it reveals sensitive information about them, and not exclusively if it's used in a way that would directly cause them harm or conflict with their conception of privacy. So this was really a holistic conception of privacy law, and his views have been very influential in informing European approaches to data protection and privacy. When you think about things like the General Data Privacy Regulation, General Data Protection Regulation, Weston's style of thought is one of its major influences. The last thinker that's relevant to think about in this space right now is Shoshana Zuboff. And Zuboff's contribution to the literature, in a word, is to say, well, in the 21st century, it's not just about the intentional use of information to affect a person's interests. It's about how your information changes the opportunities and the options that are presented to you. So in other words, algorithms are constantly in the process of gathering information about us and presenting us choices that are based on that information, presenting us signals that are based on that information. And we literally don't have the same opportunities, the same options presented to us, the same information influencing the way we form our worldview. That information is presented to us based on our own information, which we are granting to companies that then process it and refine it into advertisements, into media that's targeted, and so forth. And so Zuboff's contribution was really to shift the lens from exclusively privacy to the policing of how algorithms use information to affect our interests and to give us opportunities or take them away from us. In terms of tangible substance, this discourse led in the 1980s to the formulation of the OECD privacy principles. And this is the bedrock of every privacy law that's in force in the world right now. This was essentially a compromise brokered between the United States and the European Union at a time when information technologies were being disseminated into consumer contexts, and really these industries were growing. The United States wanted to have a relatively light touch approach to privacy regulation, whilst the European Union, nation by nation, was slowly starting to implement discrete, different privacy laws. And there was a real fear that if different countries didn't come together and set a common set of privacy standards, both the law would lose its teeth, because little localized jurisdictions would be suing large multinationals on the basis of their local privacy law, and so there would be limited potential for enforcement. But also it would be extremely economically inefficient to have organizations that were thinking about selling, software or building a website, working across hundreds, if not more than hundreds, thousands of distinct local privacy frameworks. And so on that basis, these 10 principles were proposed as the bedrock of contemporary privacy law. And really what they say, there's a lot of text there, but all it means is collect as little information as you need to do something. Don't share it onwards unless you have a good justification for doing so. Don't use it for purposes that you didn't intend at the outset or that aren't related to your initial objective. And if you're going to use the information, be transparent, be clear in what you're doing, and hold yourself accountable towards the individuals, towards what they call data subjects, when things do go wrong or when you make decisions that affect their interests. So those laws have been disseminated into the Canadian context, and what we find ourselves with, which was probably unsurprising, is an awkward portmanteau between the European generalist approach that wants one privacy statute to apply in all settings and really almost a constitutional law approach to privacy, versus the American approach, which is extremely narrow and sector-specific and contextual. So in the American approach, you only have privacy rights when you're operating within a certain economic sector that gives them to you. Think, consumer practice or healthcare, things like that. And so we're going to run through all of the different privacy laws in Canada really, really quickly. And the purpose of doing this is to understand what people mean when they say, well, Canada's health data ecosystem is incredibly fragmented. One of the reasons for that is because of these structural privacy laws. So Canada regulates according to 3 different sectors: private sector, health sector, and public sector. And within each of those sectors, there are different laws at the level of each federal government and the provincial governments. So in other words, each province has laws that apply in both the health in the private sector and the public sector and in the health sector. And the federal government also has a public sector law and a private sector law. So depending on which province you find yourself in and which sector or sectors you are working across, you can find yourself regulated by a large number of different laws at the same time. Now, structurally, these laws are not so different from one another. The private sector legislation essentially imposes all of the principles we discussed earlier on the users of information, and requires them to obtain an individual's consent to use their data. So if you're in the private sector, you have latitude to use information more or less how you like, so long as you gain individual consent. In the public sector, conversely, the government has broad powers to use information in any way they might desire, so long as it relates back to a public objective. And lastly, the health sector is, again, something of a blend between the two. Health sector organizations have broad powers to use health data for specified health purposes. So here we can think of public health, quality assurance, clinical care provision, health policy making. They don't have broad powers to share information, so it's generally expected that they will retain that data within their own institutional boundaries and not share it elsewhere. And I'm sure many of you are thinking right now that in your healthcare activities, especially those of you who are researchers, it's relatively easy to gain access to research data, or at least it's easier to gain access to research data than it is to gain access to data for clinical care, quality assurance, other activities like that. And the reason for that stems back to the law. Within the context of research, we have harmonized completely the way that we regulate health data, and we've essentially said you can make secondary use of information so long as you refer back to an ethics committee, get an ethics approval, and either get a consent or an ethics waiver of informed consent requirement that allows you to use that information. And lastly, we also need to put in place safeguards that make sure that the balance of risks and benefits for research participants are no worse than they would be if you hadn't used that information. And because this regulatory mechanism derogates out to the expertise of research ethics committees, it means that we're able to align on secondary use of information in spite of the fact that there's a constellation of distinct and incompatible privacy laws that apply at the level of the country. And this, this analysis that's performed by ethics committees actually predates the existence of privacy law altogether and goes back to bioethics principles that are used to make decisions about research generally, and which date back to the 1940s, the 1950s, and 1960s. So in other words, we've achieved compatibility, interoperability at the research level by delegating out to an institution that exists within healthcare organizations, within all healthcare organizations, that has established workflows and practices, and which is reasoning from a body of norms which are familiar to ethicists and healthcare professionals world round. Now, the big challenge that this creates is the challenge of interoperability and scalability.
But can you define bioethics?
Oh, yes, absolutely. So bioethics is essentially a body of literature or a body of research that is drawn from both human rights traditions and philosophy. I think it originally originates back to religious studies, and it's basically a way of looking at ethical trade-offs in the healthcare context and making decisions about how to guide clinical care or how to guide research activities, but it's not constrained to just what's written in the law. And bioethicists are hired on by hospitals, by research organizations, in order to provide ongoing guidance to their healthcare professionals in how they should structure their clinical care where an ethical trade-off arises. So it's not just a compliance department that tells you, well, this is the law, this is what you're allowed to do with your patients, this is what you're allowed to do with your research. It's really about finding how to balance risks and benefits in a way that best advances the interests of the patient and best advances the interests of the community and society at large. And this is, ethics committees come together. They're staffed by an ethicist or multiple ethicists and other professionals such as healthcare professionals, and they will review every intended research activity, and they'll look at it holistically. So thinking about all those different aspects. What are the advantages for the individual? What are the advantages for society? How do we respect the individual's autonomy and freedom to take on risks that they understand well? How do we make sure that those risks are communicated to them in a way that's intelligible? And that's the role of a bioethicist. And they work both in clinical settings and research settings. So often your physician, when they'll be working on your file, they'll have access to an ethics helpline, and they will call a clinical ethicist who can give them guidance on any kind of ethical issue that they might touch on. I think that's an overall definition, but some people would probably disagree with how I've defined it. And then, so this problem of scale. And specifically, the issue that we run into here is that, especially when we're trying to generate AI, but more generally when we're trying to use these fancy compute infrastructures that we're investing millions or billions of dollars into, we need data from across massive research networks. So we don't just need the data that's been generated at your local hospital. We need, or at very well least, have the capacity to process data from large numbers of different organizations. And of course, those of you who work in this space are already thinking there are problems of interoperability that are baked into the data. So when I use these data sets, I need to think about whether the data is meaningfully comparable. And these same issues arise in the public policy context. So in other words, do the rules that govern the data at the institutional level play well with the rules that govern the data at other organizations? And this becomes very relevant when you've just received a $10 million, a large grant to process data across a massive network, and you realize that you need a mechanism for making sure that you're allowed to use the data from all of these organizations for your intended purpose. So you're allowed to feed all of that data into your, say, ML pipeline and develop an algorithm, or use your new algorithm to generate information from across tens of thousands of patients, things like that. And so the critique that these bioethics institutions, which we discussed a moment ago, are receiving is that they're great at making decisions at the level of the individual organization. But if you're building a 30-institution longitudinal population health study, you're going to see, okay, we care about determinants of cancer at the level of 30 different hospitals across Canada. And we want to see if the outcomes are similar based on different environments, based on the fact that the populations are different, and so might have different, whether it's determinants of health that are environmental or genetic, they might have different responses to similar treatments, they might have different pathologies. And you need access to information from all of those sites to do that. So some colleagues and I a few years ago did a study to look at 20-some, I think it was 26 or so, different population health studies across Canada and Europe. And we cared about looking at specifically population health studies simply because they tended to engage the same governance issues. In other words, we were looking at common scientific endeavors because we wanted to see how differently they approached governance, and if the differences in governance came from actual different underlying policy issues that they were facing, or if different organizations were simply coming to different decisions because they didn't have a mechanism for coordinating together and coming up with similar rules for how they could make secondary use of data. And in looking at population health studies and looking at one thing scientifically, we could exclude the fact that different science might be explaining different governance. So what we found here is that this is a chart of how open the permissions in these different data sets were. Green means very open, you're good to go. Red means there's a lot of restrictions. The other colors land somewhere in between. We found that most of these population health studies were allowing the secondary use of research of data for research purposes. You can see there's a bit of red, there's a bit of other colors, but generally speaking, they were all aligned on, yes, let's make secondary use of data. When we started looking a little bit more deeply into the kinds of governance controls they were associating to their information, we saw a lot of differences. So some organizations allowed the use of data for specific healthcare purposes, some allowed the use of data for commercial use or non-commercial use. Some organizations required you to be looking at a specific disease or a specific underlying health issue. Some insisted that you collaborate directly with them, that you not use it exclusively for your own purposes. Some of them had bespoke administrative processes in place to determine who could use their information and how. So in other words, this data suggests that absent some kind of coordinating device, some kind of institution to help people make common decisions about how data could be used, organizations will make very different decisions about what can be done with their data. And we did the same thing again with mother-child birth cohort studies in the Canadian context. So basically studies that look at mothers and their children over over a long period of time, over the the life of the child, so generally from age 0 to age 17, 18, something like that. And again, we found that different organizations were making really different decisions about how the data could be reused, which suggests that if we want to create and preserve our health data commons, and if we want to make a health data commons that is accessible to Canadian researchers at low administrative costs, at low transaction costs, we need to be thinking about governance at more than just the local institutional level. We need institutions that can coordinate across those bodies and allow the secondary use of research data on common grounds. Now, privacy law is undergoing a massive shift. And in part, it's responding to exactly what we just said, the need to create institutions that act not just at the institutional level, but at the national or even international level. And in doing so, what it's doing is shifting authority for making decisions about how data can be used from healthcare organizations, from healthcare research ethics bodies, to central custodians and central stewards at the regulatory level, so data protection regulators. Now, what is data protection? Data protection is a new body of law. It dates back at its earliest form to the 1990s, and it's come much back into focus with the recent implementation of the General Data Protection Regulation, which creates holistic rules for how you're allowed to make secondary use of data, agnostic to which purpose you're using it for, what economic sector you find yourself in. So the European Union has recently released a body of new laws which essentially create general rules for how public sector institutions must share their data for secondary use by both the public sector and the private sector, how individual privacy should be safeguarded, and what kinds of bodies should be empowered to make decisions about the secondary use of data within the health sector. So they're creating what we call health data access bodies, which are basically central clearinghouses or brokers that will decide how existing data about people's health can be reutilized. And the critique that I'm raising is essentially that the general intent behind these laws is very good, but what it's doing is it's taking authority, taking capacity for creating rules, pragmatic rules, about how data can and should be repurposed, and shifting that decision-making outside of patients, local stakeholders and communities, and data governance professionals that already operate within healthcare organizations, and shifting that locus of responsibility to new organizations that don't exist yet and don't have the capacity and the know-how to deal with these challenges in a way that brings together the interests of multiple different stakeholders. That's a pretty heavy claim, and I'm going to give a few examples that back it up. So this is a recent decision by the Court of Justice of the European Union called Schrems II. Some of you may recognize this face as Max Schrems, who's an Austrian law student that rose to world fame by suing Facebook to have the agreement between the United States and the European Union, which allowed data to flow between those two countries, and had it struck down on the justification of fundamental rights to privacy. And then after the EU and the United States negotiated a new agreement to again allow data flows to resume, he sued again and had that one struck down too. And so now we're living in the post-Schrems limbo, where there is more or less no legal regulatory pathway to share information from the United States, from the EU to the United States. But more interestingly for our purposes, the Court of Justice of the European Union held in that decision that all organizations in the EU sharing data outside of the EU needed to ensure that the fundamental rights to privacy were maximally protected by conducting analysis of the recipient country's law and seeing if it held privacy to the same standard in the same ways as the EU did, and where it didn't, to implement robust technical measures to safeguard individual privacy. And that's an excellent intent. But as we looked at in the research context, in the healthcare setting, generally speaking, organizations are trying to balance risks against benefits. And so there's no single normative goal that outstrips the others by definition. There are different normative goals, including both the protection of privacy and the enabling of downstream use of information, that are both privileged to an equal degree, or at the very least, are left to local health institutions to decide how to best balance them. And so what this shift has done is to leave many health sector organizations in the EU unclear how to best share data with research collaborators in third jurisdictions. Two other quick examples of the same trend is a recent decision made by the Ontario Privacy Commissioner under PHIPAA, which is Ontario's health sector privacy law. And that decision basically responded to the misuse of health information by a research body in Ontario. Essentially, they had let some of their ethics approvals lapse, and they had engaged in a few practices in obtaining patient consent, which didn't respect the law. So for instance, they relied on implied consent based on a poster left in the doctor's office to obtain your consent to the sharing and pooling together of your data, rather than getting direct consent from patients. And so that decision has a lot of really interesting information in it. But one kernel that comes out of it is, again, a tendency of the regulator to shift the locus of decision-making around the research use of data away from health sector organizations and back to the privacy regulator. So what they said in this decision was essentially that they noticed a trend of healthcare organizations creating local bodies to make determinations as to how data could be reused under the rules that apply to research, when in fact they should use pathways under privacy law that left the organization and the privacy commissioner to jointly determine the conditions of data reuse. So that's the shifting of responsibility out from the health sector itself back towards the regulator. I thought there was a third one, but it looks like that's my second example, or maybe there was a third one in there. In any case, what this leads us to conclude is essentially that, it's still working. Essentially that there's a massive shift of the locus of regulation from the health sector internally to external privacy regulators. The problem is that privacy regulators are typically not particularly accessible to the targets of regulation. In other words, you as a researcher or you as a research participant can voice your concerns to the local research ethics committee, to the bodies within that institution, and get meaningful feedback as to whether the things you're doing to safeguard patient privacy are responsible and are acceptable. In shifting responsibilities for privacy oversight entirely into the hands of the regulators, it creates a chilling effect on the downstream use of that information. And the proof of it is the massive shift that we are seeing towards the federated analysis of data. So federated analysis is essentially the leaving of data at a local institution on its local servers and the bringing of software algorithms to analyze that data while it stays at rest. And from an engineering standpoint, it has a number of advantageous properties. Namely, you don't need to spend all of the expensive computing resources and transfer resources to move all the data to one location and then analyze it there. So in other words, rather than pooling together a bunch of data, which means moving terabytes and petabytes and you name it of data to one central location and analyzing it there, you can instead leave it where it lies and just bring a very inexpensive piece of software to analyze it at its location and then exclusively bring out that piece of analyzed information. The other advantage that it has is that it means that identifiable information, so information that's health sensitive, that's patient sensitive, doesn't move across organizational boundaries in structuring information flows in this way. And so it has a lot of benefits from a privacy standpoint. But it's more and more being relied on, not only because it's beneficial from a privacy standpoint, but also because it helps organizations avoid many of the legal compliance challenges associated to making sure that they're using information responsibly. So, in other words, the structure of privacy law today is incentivizing organizations to avoid engaging with the difficult normative questions involved in deciding to share and reuse the information of patients, of research participants, and rather than leading us to a model where people collectively make decisions across local communities, ethicists, compliance professionals, and so forth about how to balance the different normative trade-offs involved, we are shifting towards institutions that are inaccessible to the average healthcare professional, let alone the average individual, and we are avoiding engaging with these normative questions altogether.